Before we get started, please remember this podcast is for general educational purposes only. We're not providing medical advice, diagnosis, or treatment. Always consult your own healthcare provider about your care. Welcome to Fertility Nurses Unfiltered. 2 nurses, 1 mic, no bullshit.
I'm Ashlee LaRue, fertility nurse and founder of Fertility.
And I'm Laura Wepler, fertility nurse and founder of Navigating Fertility with Laura.
You got questions, the internet has a lot of opinions, but what you really need is 2 fertility nurses who aren't afraid to tell the truth.
No scripts, no sugarcoating, just honest, evidence-based nurse-to-nurse conversation. So let's get into it. Hey everyone, welcome back to this week's episode of Fertility Nurses Unfiltered. Ashlee and I are super excited to be back with you again and really excited to be having today's discussion all about the LGBTQ plus fertility, inclusive care, talking about Pride Month. Really excited to have Dr. Keri Bergin here with us. So I'm just going to give a little introduction to Keri, but then Keri, I would love you to kind of give us an introduction in your own words. But Keri has a story unlike almost any other doctor in her field. She didn't start in med school. She started at the front desk of a fertility clinic, and then she became an IVF coordinator. And then she went back to school, became an OBGYN, did her fellowship in reproductive endocrinology and infertility at RMA of New York, Mount Sinai, and now practices at IVI RMA Southern California. She has presented her research nationally, published in some of the top journals in reproductive medicine, and has built a practice around something she deeply believes in, that everyone deserves a path to parenthood. She is based in Los Angeles with her wife, and today she is here to talk all things LGBTQ plus fertility, family building, and what truly inclusive care actually looks like in practice. So welcome, Keri. So great to have you.
Thank you so much for having me. I'm excited to chat with you guys today. It's good to see you. So yeah, I started at RMA New York and then went back there for my fellowship. So it is a fun full circle story that I feel like people love to hear about.
Yeah, I think that's when Ashlee and I first met you. We were like, oh my gosh, we have to have her on the podcast. Like, she knows the fertility clinic from all aspects. So I think that's really cool. Like, tell us a little bit about like how you ended up in the front desk of a fertility clinic.
Yeah, so when I was in college, I was pre-med, so I did know I wanted to go into medicine, women's health in general. And then when I graduated, I was 21 years old and was looking for a job in the city in New York. And I actually, it's so funny, found the front desk job at RMA New York on Craigslist at the time. Which
I forgot about Craigslist.
So random. Shout out Craigslist. But yeah, then I started working at the front desk there. So that's how I kind of got in. I knew that, med school or women's health in general was my goal, and I kind of wanted some different exposures to different types of women's health before getting there.
That's awesome. Would you say that then working in the fertility clinic is kind of what fueled that passion and pushed you towards like working and like getting certified as like an REI?
Yeah, totally. I feel like you kind of said, seeing it from the whole patient journey from like the front desk through IVF and pregnancy and discharge and all the different aspects of it. I loved the field in general. I felt really emotionally connected to the patients. Even again, being at the front desk, the connections that you make there from patients coming in so regularly. I'm like friendly with some of them that I knew back then. So that was, it's just such a beautiful kind of field of medicine, I think. And then ultimately I went to med school at Jefferson, and I kind of, everyone is like, keep your mind open, stay open-minded about what specialty you want to go in. And you obviously want to learn about all the different specialties, all the different options. So, you have to go through all the rotations anyway. And I kind of, not to say by any means like pushed down my interest in fertility, but was just kind of like, what else do I like? Is this definitely what I should do? So yeah, ultimately went into OBGYN, and similarly there, when you're in residency, you're like kind of in the moment and needing to learn everything you can on each rotation, and while still keeping that path of fellowship in your mind, but staying again open-minded.
Yeah.
But it
That's
was
so
the right
cool.
field for me.
That's so cool. I'm not sure I've ever heard that like story or transition from like any other doctor in general that I've ever worked with. I just think that gives such a cool, well-rounded perspective that not everybody has. Like it's one thing to say you can put yourself in somebody else's shoes. It's one thing to say like you respect and enjoy working with people that support your role and all these things. But it's one thing to like be that person, and then now to be, I'm assuming, a colleague of maybe some of the doctors that you worked with as a coordinator and as a front desk at RMA. Am I correct?
Yeah. I mean, I'm at a separate practice event at RMA in Southern California, but like ultimately the world of REI is not that big to begin with. So yes, like colleagues across the country now. But the story gets even crazier. I don't know if I've even told you guys this, but like I'm one of four sisters, one of four girls, and all four of us have worked at the fertility clinic. All four of us have worked at RMA New York, actually,
Oh
in
my gosh.
different capacities. So like
That's funny.
it's so crazy, but I was there first, and then my second sister Katie, third sister Colleen, they also started at the front desk at some point. Colleen became one of the doctor's like primary assistants, and then she actually went back to school and became a nurse, and did like hospital like OB/GYN nursing for a bit, and then went back to RMA to be a third party nurse. And Katie has stayed there. She's been at RMA New York over 10 years, and she's like the director of patient experience. She's kind of in the sort of marketing side of things. And then my youngest sister, Casey, she was an embryology lab tech for like a year.
I think that's really cool. I think our generation doesn't stay in at the same company long term. Like I feel like our grandparents, our parents, not everybody, I'm generalizing, but like my father-in-law, for example, was at GM for like 40 years, and his brother was at a glass company for the same amount of time. Like I just
Yeah, it's like much more common to kind of jump around to jobs now.
Yeah, so I think I think that says something about RMA. Like if, take out the whole like they're a good fertility clinic, like I think it says something for people who are working there to want to stay there in a variety
Yeah.
of different roles and capacities, and then for you to want to actually be a doctor and go back there and work as a provider. Like I think that says something about an
Yeah,
organization.
we definitely have like, and again, RMA New York is separate than this like RMA network I'm in now, but like we always joke like the Bergin girls like are obsessed with RMA, and we just all keep going back there. But yeah, there really is a family vibe there that we really became a part of and felt really special to us, and it really like because we're all in or we've all been in the field at some point, it makes for like fun family parties or family groups. Like, we're like, oh, what's going on with this? Like, I heard about this. Like, they feel like my sisters are able to really get a little bit more of what I do.
Yeah. I'm sure that makes for some interesting Thanksgiving conversations.
Yeah. Just like talking logistics, talking shop.
Totally. Well, I really want to get into a little bit of your background as identifying as a member of the LGBTQ plus community. Obviously there's a huge subset of patients that walk through the door of a fertility clinic who are there to need assistance building their family because they can't build their family in a traditional way. And so I would love to kind of talk about that a little bit and, maybe how your identity and background has maybe impacted the way that you practice.
Yeah, definitely. Happy Pride, first of all.
Yes, happy
I
Pride.
got my Pride nails.
I love it.
But yeah, so I mean, obviously, or not obviously, but a lot of people in the LGBTQ community obviously need assistance in getting pregnant, and so we can really play a big role for them and for our community in general. My wife and I went through some fertility treatment to freeze embryos, so we haven't kind of gone down the full parenthood path yet, but it is interesting to be a patient in general, and when she first did her scan or her first round of IVF and her numbers were kind of low and she was, in her late 30s, we were like, what if this like doesn't work? And we kind of like needed to like, same with heterosexual couples that are experiencing infertility, they obviously have a need as well, but we were like, this is how we're we need to build our family. Like, what if we really get nothing from this? And we don't have a chance at even trying in a certain way, you know? So I think that it's unique in that way. And you don't really realize the feelings that come along with it until you're in it, kind of.
Yeah, that makes a
Yeah.
lot of sense.
Yeah.
Yeah.
Like we thought, like, oh, we're just freezing embryos. Like it'll, you know, we'll see. And then, you know, once you're in it and the realities kind of start hitting, you're like, oh, like this is really hard and we need this. Yeah.
I think that unfortunately there's just an assumption that, you know, that your community, that you obviously need fertility treatment in a lot of scenarios to have your family or do family building. But I think it's assumed that there's not an infertility component, right? Like, or that they, you know, you won't see, like, once you go through testing, like maybe you've never attempted before. So that's a different scenario than somebody that's been trying for 6 months, a year, plus all these things. But endometriosis still exists. PCOS or PMOS now still exists. You may have never tried before, given, you know, your sexuality, and then you get there and then there may be a diagnosis that comes up. I think there's just this like thing like, oh yeah, we have to, like, you know, that they have to use donor sperm just given whatever. They have to use a gestational carrier, an egg donor, you know, depending on the scenario. And it's like, no, you also still go through the same process. We're still going to do testing. We're still going to do this workup, and we still may find things. We're still you're still human, like, just because of your orientation.
Right. We're just still subject to like the statistics, unfortunately, you know, like you think, I do think I have some patients that come in that, I don't know, maybe feel like, you know, we just need the sperm, we just need donor sperm, and then we'll kind of be pregnant. And sure, like, yes, for some people, right. But it can still be a really hard journey for a lot of people. I think that it's easy to also forget, just in the general population, for heterosexual couples starting to try to get pregnant in their 20s and early 30s, the chance of success each month just trying on your own is around 20%, you know, which I think is a lot lower than a lot of people realize. And so when we're starting with a lesbian couple, for example, with donor sperm, like, we can't do better than that, really, you know, like, it's still going to be that rate, which means it can still take time and it can still take multiple cycles, unfortunately.
Yeah, that's a really good point. Thinking about the 20% statistic. And yeah, I think we've talked about this before on the podcast, Ashlee. It's like, I think we've all been raised our entire lives to think that it is so easy to get pregnant and it's just going to happen like the first time that you have sex, and not realizing or thinking about that is actually a pretty low percentage each month that you have chance of conceiving naturally.
Yeah, the hard thing about percentages in general are like, you either end up 100% pregnant or 0% pregnant, you know? So like you don't end up like 20% pregnant, right? And so it's really, I think, hard for like people to totally grasp that sometimes, because like, oh, they got pregnant the first month they tried, and it's like, yeah, and then all these other people didn't, right? Like it's just because it's just, you don't see the percentage. You're just like, it happened or it didn't happen. It's hard.
Yeah. I would love for you to kind of talk a little bit, if you're comfortable with it, like you and your wife, like the process of selecting a sperm donor. I feel like I talk to patients all the time and they kind of tell me what that's like in a way, but I would love to hear from your perspective. Like, what was that like for you and your wife to be looking through?
Well, I mean, I was always like, I would never use a known donor. Like, we don't need a man in our life. Like, I don't even want to know he exists. Like, we don't need a known. We wouldn't use a known donor. But we used a known donor, actually. And so we were starting our kind of journey, whatever year it was, and thinking about it. And we had gone upstate to visit friends who are a gay male couple who had their first child, who was maybe, 6 months old or something. And they actually used a known egg donor, one of their friends. And anyway, we were chatting with them and saying, yeah, we're going to start, we're going to start looking this, that. And they were like, oh, like, why don't you use our sperm? And we were like, oh, that's funny, laughing about it. And they were like, you laugh, but like, that's how it started with us and our egg donor. Like, you never know. And we really went home and we like kept thinking about it. We were like, I mean, it does kind of makes sense. Like, maybe we should. And like, they have a child through known donor. And so they really understand like the boundaries of these relationships and the experience and everything. And so we reached out and we're like, are you serious? Like, should we talk about this more? And yeah, so we actually never even like did the kind of donor sperm Tinder swiping. Yes, no. I kind of like wish we got a little of that experience. We should have started, but yeah. So we went with.
That's a whole totally like experience in and of itself, because clearly this couple, and where the sperm came that helped to create these embryos, like, and it sounds like you haven't put those embryos to use yet, but like I guess I'm curious on the dynamic of what that will look like once you do.
Yeah. I mean, this is like, good friends of ours, but honestly, not like best friends where we see each other like all the time either. So it's nice having a little bit of space from it. But I think everyone's, comfort level with what that relationship will look like is so different. Like some people might want that like super close person. Some people might, want a very distant person. That they maybe though have some connection to or something, but ours is maybe somewhere in between that kind of. And yeah, I mean, I think there's cousin vibes involved, I would imagine. And yeah, I think everyone's experience is going to be so different with it. And I just don't know exactly what ours will look like.
Yeah. Is this something that you, because obviously going through the process, there's different components. There's a psych, you have to go through psych evaluations and legal stuff and all. Like, is this something that's like semi already detailed out at this point in the process of the involvement, I guess? Or like, there's so many legalities that go into this that I don't think a lot of people think about.
Yeah, so I could tell you the way we kind of do it at EVRMA. When I'm talking to the patient and I tell them we get to like the sperm slide, and I'm like, there's known donors and anonymous donors, and like, what does anonymous really mean? And within anonymous, open versus like less open, whatever, all these different kind of categories. But yeah, the kind of first step we usually do is genetic testing, to do genetics and see if you're a carrier for anything, make sure it doesn't overlap with a donor. When you have the option of choosing in particular, right? Like you want to make sure there's no genetic conditions. We do CMV testing, which we can talk more about. But then we talk about we do a one-time reproductive psych appointment for the patient, and the donor has a separate one. And then they have one together to kind of talk through those relationships. And like, the idea of the reproductive psych, I always get a little bit nervous. I'm like, it's not to see if you'll be a good parent. It's not to decide that. We already know you will be. But, it's really to talk about the complexities of kind of raising a donor conceived child and their needs and their sense of identity. And, they don't necessarily need to know who their donor is, but they should know that they were donor conceived and why it's important and everything. And I think, I would always get like nervous telling patients that they're required to do it, because it just feels like another, barrier. Yeah. But I feel like all of my patients have gotten a lot of value out of those appointments. Even when they're using an anonymous donor, we have them do one-time appointment. But yeah, I think they've gotten really liked it and been like, oh, that's great, that's good. And then if it is a known donor, then there's other kind of FDA blood work requirements, FDA physical exam requirements, and we require them to have a legal document made up around the like relationship or around the donation, I guess.
Yeah. Talking about this, kind of going back to what we were saying about, this assumption that maybe it's easier in the LGBTQ plus community, right? Because there's maybe not an infertility diagnosis, but just as we're talking, I'm like, there's so many other layers here that isn't necessarily involved in maybe a heterosexual couple walking in the door, doing a couple IUIs and getting pregnant, and even an IVF cycle. I mean, again, we always talk about this every week. Fertility is not linear. And so that can look very different for everybody who walks through the door, but there's certainly a lot of additional complexities in the case of needing to use a sperm or an egg donor or even a gestational carrier.
Yeah, 100%. Yeah, like, we have like these checklists of things that need to get done before people can start their treatment. And yeah, it's hard because obviously you don't want to overwhelm people even more and be like sort of, gatekeeping access to these things even more. But when we're on our side facilitating it, we just want to make sure that they have all their protections in place, that they're making all the best decisions for themselves, the safest decisions, that we're screening as safe as possible for them and for their future child. But yes, there's a lot of things on the front end that are hard to go through, I think. Just add to it.
Yeah.
I think, and I'm curious if you or your wife experienced this, and maybe not, because if you went through RMA, I'm sure you have a lot of great things set up. But I think a lot of fertility clinics and fertility treatment is very much set up in like a heterosexual domain, right? Like it's talking about, oh, there's questions about your husband, or there's questions about like if it's like a same-sex male couple coming and it like requires you to answer your last menstrual period and it like doesn't let you skip it. I think there's things like that I think in the clinic setting we can all do better. And as we're educating and using the right pronouns and not saying things and not assuming husband, wife, or even spouse or whatever, maybe you didn't experience this, but maybe you've encountered other patients that you work with that have experienced it, like that gap that still exists, unfortunately, to this day.
Yeah. Yeah, and I will say I do feel like it's gotten so much better, honestly. Like I feel like there is so much more awareness about language and why it's important to people. And obviously can't speak for everywhere, but I hope that it's gotten better most places. And I think it helps that there are those intake forms ahead of time, though, too. Again, I'm sure they're not all perfect. I think there's more write-in things these days to add something, but certainly we require people to do the intake ahead of time, which just helps in like, preparing for the patients you're about to see so that you can get the most out of the visit. Yeah, so luckily, although, it's so hard to say, like, have I experienced that? Probably, who knows, right? Because you just like go about your life. But again, I do think it's getting a lot better at least. And yeah, some things you just don't know until people, point out to you, like, oh, it won't let me actually skip this field or something. Like, I think it shouldn't be obviously the responsibility of the patient, but it obviously helps us learn where there are gaps if we get feedback on it.
Yeah.
For the I had another question I was going to ask and I'm blanking, so you'll have to cut this out. Sorry, Laura.
That's okay.
Oh my goodness. Brain fog.
It's one of those days, man. That's
I
what my
guess
brain's at
so.
right now too.
What in the world? I lost it. So
Well, I could tell you, I could say like um the way I start most of my appointments in general, because the intake form doesn't have everything on it, right? And it doesn't leave space to sort of add everything either. And I start almost all of my new patient visits by kind of like, tell me about yourselves, tell me about you guys, like, how did you meet, when did you meet, where are you from, like, what's your relationship been like to kind of just get to know them a little personally first. First of all, it helps me like know who they are more rather than just a name or a face, like kind of some information. But I feel like it also gives opportunity for some of those stories to come up of, like I didn't want to put on the paperwork, but X, Y, and Z, so for people to actually be able to tell their story in person before we kind of dive into the medical side of things is what I have found to work well for me.
Yeah. Have you encountered many patients in your practice that are maybe trans and coming in to freeze eggs like prior to making a full transition? I know there's a lot of dynamic that goes into like that experience just from a mental health aspect. I know that can be very difficult. I'm just curious if you've had any of those encounters.
Yeah. I haven't had a ton here in LA just yet, honestly. I moved here last year and started practicing in the fall. At RMA New York, we were like a very big clinic. And so definitely we saw more patients there. Some of who are coming in for freezing their eggs before starting therapies, but a lot of people coming in once they've already been on therapies and want to talk about options still. So it's still very reasonable to do it that way. And I think, again, there's been a lot of change and more of a push to introduce some ideas sooner than later, while not, pressuring people that they need to build a biological family either. It's hard to find that balance a bit, but it's really just more about education and knowledge of the options, I think. Yeah. So not a ton here, but more there. And actually, RMA New York did publish a study on outcomes for trans folks undergoing egg freezing, and there's not a big standard around it because it's still a smaller population overall, and so there's different ways to approach it. But we're finding that it is okay to stay on testosterone replacement while undergoing the egg freezing process. And so we kind of talk about it. I kind of approach it similar to how I approach people on birth control pills in general. So basically, hormones can sort of suppress the signal from your brain to your ovaries to grow eggs. And if you've been on things for a long time, then the ovaries might be really suppressed and that signal is really suppressed. And so if I look at someone's ovaries on ultrasound and their egg counts are much lower than expected for their age and the ovaries look small, then I'll lean more towards talking to them about, like, maybe you could benefit from being off it for a month or two. But also, I can't say for sure, honestly. Some people just have lower than average egg counts. If someone has a normal egg count for their age, I can have the same conversation of, like, could you come off of it and we get a few more? Maybe, but also this number's good. So if we can get what's there, you don't necessarily need to stop, with the kind of shared decision making, understanding that, like, maybe we could do a little better, but we don't know. We don't know for sure. Every cycle is different. It's so hard to actually study that and compare.
Yeah.
I think those conversations and transparency are like something that's really missing. And I think a lot of really wonderful doctors like yourself have those conversations, but being out and working with people across the country from a variety of different clinics, that's not the case all the time. It is like, there are some clinics that very much approach a very cookie cutter approach to these things and don't have those type of conversations and are working off of potentially older data, which is not great either. So I think back to that example, I think the fact that you all are studying, and again, a small sample set, but it would be so nice for people not to have to come off of the testosterone, because that, like, the feeling, I can only imagine,
Yeah.
you've made that decision, you're making that transition, you're feeling good in your body, you have this, you have this identity, like, and then to come off of that and then to do something that maybe feels extremely feminine when maybe that's not your identity, I can imagine, like, that can be traumatizing when you're just
Totally.
wanting to preserve fertility, and to do a study that specifically looks at that and say, you know what, you actually potentially could, let's have that conversation, let's say what that looks like for you as an individual.
Right. Like, weigh the risk and benefit of it. And only you kind of know it's a personal decision in terms of your timeline, your gender dysphoria, your, experience overall.
Yeah. There's a doctor I worked with previously through CCRM, and she did reciprocal, I believe it was reciprocal IVF with her wife. And I just remember her being very open and transparent, talking about, like, both of them never necessarily wanted to carry. I think she was very much like didn't want to carry. Like, she did not like being pregnant. They have 2 kids and they each carried that. I think they might've each donated. I don't remember the whole story, but like that sort of, like, yes, you want to build your family, but then potentially needing to be required to do something that maybe doesn't feel right in your body, and, like, being excited about building your family, but then potentially, or preserving fertility, but then doing something that just doesn't feel right for you in your identity. I don't know if that makes
Yeah.
sense, but, like, I just
Totally.
very much, like, appreciated her talking and being very open and candid. That's like, her and her wife wanted to build a family. I think people just automatically assume that like women want to be pregnant, or they enjoy being pregnant, or they enjoy the process or whatever. And like that, no, like that could be to any couple or any individual, but like that was
Yeah.
specifically for her. And I just really appreciated her talking about that.
Yeah. I mean, pregnancy is a whole nother like beast of a thing. I feel like, like, I mean, that's obviously such a long journey of actually being pregnant. I do feel like people end up surprised when they hear, egg freezing or the IVF simulation part is only 2 weeks. Like I feel like everyone's like, oh, I thought so we on injections for like a year, like a long time. Which of course I'm like, well, everyone's journey can be different, and you might like it. You could be on and off of it. It can take more than one cycle, and so then can really feel like a year, but or it can be a year just as you're going through the treatments. But that the actual simulation is 2 weeks, I feel like makes for a little bit of an easier, decision than like pregnancy itself, which is just, so hard.
Yeah.
Yeah.
But even on that same kind of vein of like feeling uncomfortable in your body going through a process that maybe wasn't a process that you ever thought about going through. I mean, I've definitely worked with couples before, reciprocal couples where they go in thinking one partner is going to be the egg source, and then they come to find out they're really not the best candidate, and really their partner would be better off going through stimulation and egg retrieval.
Yeah.
And I imagine that's something just that you've maybe navigated with couples before.
Yeah. I mean, I've definitely had a lot of couples like that, and it's hard. Yeah. You kind of come into it thinking like, oh, we just need the sperm, right? Like that same kind of thought process. And you don't realize, the full picture of age-related infertility in general, or age-related outcomes, or other diagnoses that can come up and whatnot. So, it's definitely hard. And yeah, I'm thinking of a couple I just had recently where, they just wanted to try with one of them, and we went through the numbers, the stats, and, she just felt like she needed to try, right, to have that chance. And they totally got it. They understood. But, unfortunately we didn't end up with the outcome we hoped for. And it's still just, shattering to feel like that is then just taken away from you. Something that you thought you had a shot at. Even when the percentage is low, it 100% happens or doesn't, right? So you have to kind of have that hope that it will. But she just wrote me a message the other day and was like, at the end of the day, like, well, she actually said, like, if I may, like, happy Pride, just to say that first. But, it feels like such an honor to be able to go through this process as a lesbian woman, like, regardless of sort of the outcome. And it's true. We have so much more technology and access to things now that our community has not had in the past. I mean, you don't see a lot of older LGBTQ parents for a reason, right? Like, I mean, it first of all wasn't really acceptable, right? Like if you're thinking about our grandparents' generations and building your family as a queer person, just luckily a lot has changed kind of socially and technology wise to just give us options. Yeah.
I don't know if we want to go down this rabbit hole, probably not too far, but I mean, in our current like political environment, do we see that shifting back at all? Certainly not from a technology standpoint, but just from like an embryo rights perspective and, access to treatments for same-sex couples.
Yeah. I mean, it's scary, right? It's a scary, hard thing. I know, like when my wife and I, the year we were decided to freeze embryos, we got married that year. Like we just went to City Hall to get married because we're like, well, that might help with protections. We want to potentially be married at the time we, certainly like get pregnant or have a child. It just sort of helps protect your shared rights in general. And so we, just got married that year just because we were making embryos, just in case. Because we're like, I want to be sure that like the consent forms are like the married couple consent forms that we're both on, even if it's like only my eggs and donor sperm and I'm carrying, like, just that kind of added layer of protection. And so, Yeah. I mean, it's scary.
Yeah, I think that just brings up just legal stuff in general again after the baby's born, right? Like there are some states, it's very state dependent, so you'd have to look up laws in your specific state where you live. But there are some states where you could take a reciprocal IVF situation, right? So one individual creates the embryo with their genetic egg, their wife carries, right, or their significant other carries. It's like legally, I think it's the person. In some states, it's whoever gave birth. They are legally on the birth certificate, and then the person, their wife or their significant other, has to legally adopt the baby. And it's like, I mean, even outside of like the genetics scenario, right, like genetically that is their baby. There's scenarios like that all the time. We can insert whatever depending on what state. And one, I think that's crazy. I think all of us can agree that's crazy, but it's just another added barrier or layer that has to be thought about in
And even
states.
in states where it's more protected, like luckily I've obviously been in New York and California, but in states where it's more protected, and also caveat, I will not pretend to know like the everything on legal things around it. Luckily, there's reproductive lawyers who we lean on for a lot of these things, but. Even in states where it's protected, they're generally going to guide you to still get a parentage order, like a court parentage sort of thing, or like an adoption order. And I'm not exactly even sure the difference, honestly, but yeah, some kind of legal document to support your parentage. Maybe not in your state, but in case you're traveling, like to another state or internationally. Yeah,
I didn't
definitely.
even think about the travel component of it at all. Yeah.
Yeah.
Yeah. Semi along those lines, kind of not, but like let's talk about like the coverage or insurance component of it. I think we can all agree insurance coverage for fertility treatment in general needs to be better, right? But for the LGBTQ plus community, it's even less coverage, right? I think there's only 6 or 7 states that actually have LGBTQ plus language in or language like mandated for insurance to cover not having to undergo 3 to 6 IUI cycles or have to have been trying for X amount of months or a year or something. Like how do we like how do I guess my question is like, how do you as a provider, like, are you I'm assuming you see that a lot, maybe not so much again New York, California, little less so, but yeah, like navigating
I mean,
that and as a provider.
there's only so many states that just have like infertility coverage mandates, period, regardless of LGBTQ status. But only so many have mandates, and luckily California is one of them. And we are seeing, I really do feel like there's been a big uptick in coverage and the percentage of my patients that I see that have coverage in general, both LGBTQ and not, and for fertility treatment and egg freezing. And so, yeah, going in the right direction, obviously still a ways to go. And I know ASRM changed their definition of infertility, a few years ago. I forget what year it was, to include needing use of third-party reproduction as part of a diagnosis of infertility. And so now you can kind of put infertility too, because they need that. And I haven't seen it hasn't been a bit that I've seen them require a certain number of IUIs, luckily. But I think, like in the past in New York, I remember that. I mean, again, even for not LGBTQ people, where they would require like lesser before greater, like, to do 3 IUI cycles before they would cover IVF. So definitely changes have been happening. I mean, we published like a couple years ago around egg freezing and coverage. And in New York, when the experimental label was lifted for egg freezing, and we look at the numbers, 0% of our patients had coverage. And then looking at over a decade of that, so looking in 2022, pulling the numbers, over 50% of our patients had some form of coverage for egg freezing alone. Not specific to LGBTQ, but just to say, luckily coverage is expanding. and hopefully continues.
Yeah, one can only hope, right?
Yeah, we do have finance coordinators, so they kind of get into the nitty gritty of things and help guide us on what they need. I mean, I've definitely written notes just to say like it's required for these reasons, or they meet criteria for these reasons, just kind of anything to support it. I have a couple right now that's covered for same-sex male couple, covered for donor egg, the insemination of the eggs, the PGT, like, which I haven't really seen
Wow.
That's
donor
awesome.
egg coverage on it, like,
Yeah.
right, like that's really expensive.
Huh.
Yeah, I was like, whoa, it's amazing.
I mean, that brings up a
That's
good
awesome.
point. Again, kind of going back to what we started with, and that the cost, I think, can be a huge hurdle in the LGBTQ plus community, especially for same-sex male couples where they need to purchase donor eggs and a gestational carrier in order to build
Totally.
a family.
Mm-hmm.
Totally. I mean, I don't know how like anyone does it, honestly. It's so expensive. And I mean, for good reasons in some ways, right? Of course, this is a big, IVF for donor egg in general. Like donating your eggs is a big experience and ask, um, and then having someone carry a pregnancy, it makes sense that it's costly. It's just I don't know how anyone does it, and so yeah, it's just again, you look at generations of gay people and they don't have kids, right? Like they just don't. Which is, obviously by choice in some ways, but also like that means that we have a growing community, an aging community of gay people that don't have kids to help take care of them as they age, right? It's a sad reality. And I think that's why people rely on their community so much. And the LGBTQ community is close in that way because they have to take care of each other. Yeah.
Yeah,
Yeah.
absolutely.
Do you know of any, like, are there any good communities, support groups, whatever you want to call it, specifically for the LGBTQ plus population, right? Like I can imagine like going into, people that are looking for more community, more maybe mental health support, or just not feeling as like I'm the only couple or person or whatever going through all these different nuances as a member of the LGBTQ plus community, but also just in general in the fertility treatment space, right? Are there good, I mean, I know there's probably a lot of people that try, and like Resolve has great support groups and things like that, but are there like great resources that you've been able to work with or
I
refer to?
Yeah, I wish I kind of knew better, honestly. I mean, obviously, the internet is so helpful these days, and you can find people all across the country and the world who are going through it. And there's people are so much more open about sharing their journeys online now that I think it's made for a lot more connections. Trying to think if there's a group in particular. I'll have to brainstorm on that.
Okay. I mean, I just did like I didn't know, and honestly, for my
Yeah,
own benefit, right? Like I'm not 100% sure it exists or like specifically for
yeah.
that
No,
community, right? Like
it's a great question.
if it is a growing, right? It's a growing thing. We're seeing more and more people go into the space and wanting to preserve fertility or have a family and build their family.
Yeah, more and more
Are
people,
we
but
missing
also
the support?
also
Yeah.
still a few people, right? Because and so you have a gay couple in your office, and it's like, do they know any other gay parents? Like for the same
Yeah.
reasons I'm saying, right? You don't see that growing up, and so do you even know anyone who's been through this, right?
Yeah.
I can't think of a specific resource, but if I find one before this comes out, I'll send it over.
Okay,
Yeah,
cool. Yeah.
that's great.
Yeah.
I'm curious about that because I mean, sounds like it may be something that could really be needed. But yeah, I mean, I think I've heard from, other individuals and couples that I've worked with from this community that, sometimes just like walking into a fertility clinic and sitting in the waiting room and just not seeing people or seeing couples that like necessarily look like you or whatever, and then just to have like certain verbiage on pamphlets and flyers, and you see pictures all over websites and things, and it's a male and a female, and again, I think clinics are doing better. I think people are trying to do better about it and have more of that, but there is I think again, going back to that support piece, I just think
Yeah,
just
yeah, and it's so it's like so hard. I mean, it's so great, but it's also weird being in the community in ways, and never wanting to obviously make it about myself as the person's physician, but finding, depending on the patients, if it's the right time to kind of put in like when my wife and I or something about it, and have definitely seen people like relax or like ask about it. I remember one patient in the recovery room like waking up from anesthesia was like, when you said you had a wife, like I knew it was gonna be great, like whatever. Just so funny. But I think finding that balance for me at least is always interesting. Like, do I tell them? How do I tell them?
Yeah.
Like, I don't want to make it about me, but I also want to know that like I see you, and we've been through some of that.
Yeah. We've had this conversation on the podcast a couple of times actually. And like, as a healthcare professional in the fertility space, like, is it appropriate to share your journey? And like, I have my own journey, and I certainly, again, you kind of weigh like who's sitting in front of you, and you kind of can pick up on, okay, this is a person that I don't probably think I should share this with. But I think for the vast majority of couples that I've shared my story with, and I'm sure you've seen similar, like, I think the vast majority appreciate hearing that, their provider on the other side has walked in their shoes and understands the emotional component. Again, I'll say it again, fertility is not linear, but the emotions that go along with it are very linear. They're very, very similar for a lot of people.
Yeah, no, it's true. Right. Yeah. And again, you judge it and decide if and when there's a right time. And also just to kind of think of your doctor as a person, I think too, it helps to have, a little insight into their life to connect in that way. Makes it feel more like real too.
Yeah. Like you're in it as a team, right?
Yeah, like I mean, I can imagine. I mean, just to your point that we've talked about this too, like just when people hear certain things, you just like you kind of exhale a little bit, like, oh my gosh, you get it. Like I feel like this, like, yes, you're my person in this, because you become a very big component of somebody's family building journey. It's a very vulnerable time. It's a very uncontrollable time. It's almost like building that trust, right? But I would assume that people like in the LGBTQ plus community would seek out or want to know or find like somebody who also maybe similarly identifies, or at least can understand, and like like it's one thing for maybe Laura and I to talk about things and all that, but like we're still not in it, so we're not gonna fully understand it, or yeah, I can assume people probably seek you out.
I mean, I hope so. Well, let's make all the gay families out there. Yeah, I hope so. And I mean, that's why I share it. And if people feel like it's, too personal or not a good fit, obviously that everyone has might feel like someone else is a good fit for all kinds of reasons. But yeah, like that personal side of it. And then also, just what your outcomes are too. Like it helps that we had one cycle that went one way and one cycle that went a total other way, like to even be able to share like I wish I could do this all for you. This is what happened to me, just even briefly, like we just don't have there's so much we don't have control of. And so to hear that outcome isn't always perfect, even when you're on the other side of it, puts it in a perspective a little bit too. Like it's not just about you and you having a bad outcome. It's like it's unfortunately there are numbers involved, there are statistics involved, and
I would say, I think it's more uncommon to go through your fertility journey and just have it be really easy, right? Where you just like boom, 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 you do A, B, C, D, and so on, and it's just great. You have a fantastic outcome, right? I think there's always hurdles in this process, whether you're LGBTQ plus or not. There's always going to be something that doesn't, fall along the normal path.
Right. And I think you kind of think like, oh, we made the decision for IVF, so like that was the hurdle. I think some people are like that was going to be the hard part, was deciding to actually do IVF or something, and then once they've kind of made that decision, they think, well, now that was supposed to be the hard part. I've decided, so now just make it happen. Like, and it's come so far. I mean, when you think about technology and IVF success, like the oldest IVF baby in the US is what, like 44 years old or so, you know, like to think that success rates at that time were like less than 1%. And now, you know, we pulled our pregnancy rates from last year and they were like over 70%. Like it's crazy, you know, how far we have come, but it doesn't always feel that way day to day, right? Or patient to patient, but kind of big picture wise.
Yeah, we had that conversation it would have been a little over a month ago now with an embryologist that we had on, and Ashlee and I had no idea that they used to just randomly check LHs every 4 hours round the clock until somebody had a surge in
Oh,
their
they
eye.
were doing egg retrievals. They were doing egg retrievals at like 2 in the morning.
Yeah, I mean, it's
And
crazy.
they used to do it laparoscopically.
Yeah,
Like
yeah.
we were blown away. Like I mean,
That's that one egg.
yeah, he's been in the field for over 40 years and he was just telling us all this stuff that historically, and we essentially were talking about like technology and where AI is going in the fertility
Yeah.
space and what's coming and all these kind of things. It was a really interesting conversation. But yeah, like we're
Yeah, I mean, I think about the people that were doing it then, and I'm like, God, you have so much patience. Like I don't know, you know, being at RMA, we were involved in a lot of research. I mean, RMA New York and the EVRMA in general puts out so much research, and it's a big part of our field. But to do the same thing over and over again when success was so low, like to get us where we are, it just thanks, guys. Sounds hard.
are you maybe you can't tell us, but are you working on like any research right now, or RMA working on any research that's kind of cool, or anything you've recently put out that is
Yeah,
really cool that you'd like to share?
yeah, sure. This year I had, I think it was just in the like winter time. I had a paper come out looking at egg freezing. So looking at eggs that we let sit in the lab that were immature, that we let sit in the lab for an extra few hours and they reach maturity and then we froze them. And then looking at the outcomes of those kind of late mature eggs and seeing that they still have high success. They still have success, not quite as high as ones that are on time mature, but kind of adds to your whole cohort of eggs and gives you more chances for the future. And then I have a paper coming out with progeny this summer, just kind of looking at, you know, now that success rates are so high, the next sort of question is how do we make sure they're the safest kind of cycles too? You know, like now we're getting people pregnant, and how do we make sure we're doing it safely and limiting like multiple gestation pregnancies? So that'll kind of be the next wave of, I think, IVF is making sure it's very safe.
Yeah. I mean, you think
And then
about back in the day when not only were we doing LH checks every 4 hours, we were putting like 8 embryos in somebody and
throw them in, cross your fingers.
yeah.
Yeah, I know. It's scary to think about. And sometimes even still you see places putting in more than one, you know, tested embryo. You're like, oh God.
Yeah. But then again, you know, I love talking on the research topic, because I think this goes to one of the reasons that I love this field so much, and probably all three of us can agree. Like, it's just awesome to watch how ever evolving it is, and all of the things that we are going to be able to do that we can't currently. And again, I said this during Dr. Joe's episode, but like, we're going to look 40 years from now, we're going to look back, and something that we're doing right now, we're going to be like, I can't believe we were doing that. Can you believe we were doing that?
Totally. It's crazy. Yeah, it's just going to keep getting better. I mean, kind of in the field of LGBTQ, we're kind of thinking about how these technology advances relate to that. When you think about in vitro gametogenesis, like where you can just take cells, right, and reprogram them to act like a different type of cell, right? So, you know, can we take cells from two women in a same-sex female relationship and reprogram one of them to act like a sperm and then fertilize that way? And I mean, it's happening, like, right, like they've done it in mice, they've recreated it in human embryos. And so, you know, it's just an interesting, of course, like we could do a whole nother hour on ethics and everything, but but you know, it's curious. And I have had LGBTQ people ask me about that, like, is that a thing? Is that going to be able to happen?
Yeah. We're probably pretty far away from that being like, I think probably a reality, at least in the next decade. But What about things like
I
mitochondrial?
don't know,
Okay,
but
I don't know. What about things like mitochondrial DNA transfer? Like, do we think that we would see that maybe in the nearer future?
yeah, definitely. Yeah, we can eliminate mitochondrial disease by, using donor mitochondria. And so, I mean, again, yeah, we think about how far it's come, and there's still, yeah, so many places for it to go. But I think we will see both.
I mean, I think it's so cool that I think fertility is one of those fields, kind of, I guess, back to Laura's point. I think one of the reasons we all like this, it's one of those fields like where we're always trying to do better. Like 76, I don't remember what you said your percentage rates were of like pregnancy rates. That's not good enough for us, right? Like we are going to keep going and find ways to make it better and make it better for different communities. And if we in the future can do that for same-sex female couples, like not even introduce an actual sperm and you could have the two eggs,
Male couples, 2 sperms.
2 sperms, like, what, like, whatever it,
Yeah.
you know what I mean? Like, I just think there's so much research and cool things happening in the field. And yes, and we're always trying to make it better and increase success rates. And you've seen that linearly, like, go in from 40 years ago to now because it is a
Right.
field that
It's
just keeps
innovative.
trying to push that
Yeah.
needle.
Yeah. And it's like, even though it's a small field in general, it like we put out so much research, right? Like, and going to ASRM is always so, invigorating, because you're like, oh, people are here, they care about the same thing, and they're excited, and just gets you all, excited to be in that energy of just wanting to see our field move forward and help more people.
I want our listeners to hear that and patients to hear that, right? Because sometimes I think it's thought that like it's a money thing, right? Like I think there's a lot of like, oh, IVF is really expensive. These clinics just want to make money. And I think we forget that we are all humans, right? You as a physician, you are rooting for your patients. Like you want them to be successful.
I'm crying. I'm up at night thinking about them. Like, trust me. It's an emotional journey. I mean, you guys have been like, through it on the professional side too. And it's like
Yeah.
you've become so attached to patients, and
Yeah.
it's hard
When they're
to not be able to do it all for them. Like,
yeah,
yeah,
exactly.
yeah,
So I think humanizing, right? That all of us providers, like we are, we get nerdy about research and excited about the new technologies.
yeah, yeah. And emotional about your outcomes too. It's just, yeah,
Yeah.
exciting, emotional field.
Yeah.
Absolutely.
I think a piece of this, and we've talked about it and been very honest about it, and I think we've talked with you, Keri, too, about it, is just like there are still like gaps in just support in general, whether we're talking about the LGBTQ plus population or we're talking about just fertility care in general, right? We all do care so much, but there are only so many REIs out there, only so many great clinics out there. There's only so many hours in the day. And it's like you've also got to have a little bit of that. Something we've also talked about is like a little bit of that self-care, and like you've got to go home, you've got to be with your wife, you've got to be with your family, you've got to have a little bit of downtime to come back and then show up for your patients, right? It doesn't mean you're not thinking about them and like constantly like, oh, I need to remember to do this, or I need to, yeah, I need to text. I don't know. You're not thinking
Yeah.
about it constantly, but there has to be like, and I think that's a piece that there is that gap. I think we can all recognize that, feeling like a number and all those different pieces. And it's like, it doesn't come from the people that have heart in it. It comes from like the system and the way things are set up, and just, yeah, there's different components that we obviously don't have to get into, but it's like us as humans, like that really do care. It's not coming, like that gap's not coming from us.
Right, the individuals. It's really such a social union. It's obviously healthcare in general, right? Like, it's just hard to be a provider in healthcare and know that, you need to see patients to keep being able to see patients. Like, and it's a kind of a cycle, and we're put into it by the state of healthcare in general. Do we have 3 more hours?
Right.
Well, we're getting to the top of the hour here, so I would love to give you the opportunity, Keri, to kind of share again with our listeners where you're located, how they can find you, like especially for those patients who are in like more of the Southern California area. Like we want them to be able to get in touch.
Sure, great. I am at EV RMA in Southern California. We have a West LA office and a Burbank office. So I'm in Burbank half the week, West LA half the week. You can find us online through the RMA Network.com website. I also have an Instagram, Keri Bergin MD, that my 25-year-old medical assistant is really on top of. She just before I left the office, she's like, "So, are you gonna post like the thing I said?" And I'm like, "Oh, don't make me." But yeah, so you can always find me there, or if that's easier, to shoot a message and we can have someone call you to schedule that way. Lots of options.
Yeah. Awesome. And of course, happy Pride to you and to everybody
Happy
listening.
Pride.
Is there anything that you can leave to our queer individuals listening or just your community in general that just kind of a last piece of just thoughts or advice or something about Pride, anything you would just like to leave our listeners with?
Yeah, I mean, I think that, while it feels like our rights are still under attack, and they certainly are, we still have so much more opportunity than a lot of LGBTQ people before us who have fought to give us the rights that we do have now, while it can still feel limited. But we do have the right to build our family, and that can look different for so many people. There's not one path for it, and there's people that want to help us build gay families.
Absolutely.
I love it. That's perfect.
Awesome. Well, thanks so much for joining us
Yes,
this week.
thank you.
So glad that you were able to come on. And for our listeners, please shoot us an email, subscribe. We want to hear from you. We want your feedback. If there's a topic you'd like us to talk about, let us know. And we will see you next week.
See you next week.
If this conversation resonated, comment, or subscribe, share, send us your questions. Nothing is off limits.
And wherever you are in your journey, know this: you deserve support that's real and human. Never forget to ask your questions, advocate louder, and remember, you're not crazy. Fertility is hard.
That's it for today's episode of Fertility Nurses Unfiltered. Thanks for spending your time with us today.
We'll see you next time.